specifically to suicide. And so we only have 3 hours, and that might seem like a lot of time. It's actually not a lot of time at all. So there's a lot of material that I'm going to try to cram in here. And I'm fully aware that I probably won't be able to cover everything. So that's completely fine, because I love follow-up. So if you have any questions that I don't get to during the training itself, or if there's certain things you'd like to learn a lot more about, please follow up with me. And I will be in your neck of the woods in a few weeks anyway for 3 full days. So whatever questions don't get answered, hold on to them. Let me know. So I want to do a really quick intro to Marshall and Hand. So those of you that have been at my training before already know this about Marshall and Hand. So this will just be a quick review. But this is very pertinent to our training on suicide. So I just want to read part of an article that was written by the New York Times in 2011 that kind of describes a little bit of Marshall and Hand's own personal background as a teenager. So this is what the article says. Marshall and Hand learned the central tragedy of severe mental illness the hard way, literally, banging her head against the wall of a locked room. Marcia arrived at the Institute of Living on March 9th, 1961 at age 17, and quickly became the sole occupant of the seclusion room on the unit known as Thompson 2 for the most severely ill patients. The staff saw no alternative. The girl attacked herself habitually, burning her wrists with cigarettes, slashing her arms, her legs, and her midsection using any sharp object she could get her hands on. So that's clearly lots of self-harm there. But then we keep going in the article. And the next paragraph says, the seclusion room, a small cell with a bed, a chair, and a tiny barred window, had no such weapon. Yet her urge to die only deepened. So now we see not only did she have self-harm behavior, but she also had some of these suicidal impulses. And so the reason they put her in seclusion was so that she didn't have any opportunity to inflict self-harm, but that did absolutely nothing to deal with her suicidal tendencies, right? Because that's separate. Self-harm and suicide are related, they're correlated, but they're not the same thing, right? You can have self-harm and not be suicidal. You can be suicidal and not have self-harm, but you can also have both at the same time. So it's no surprise that Marshall Linehan, who later became a psychologist herself, was finally able to create a treatment program to deal with both, right? Both self-harm and suicidal tendencies. So that's how we ended up with DBT. So when you look at suicidal behaviors, DBT is a really good go-to, because that's one of the reasons that DBT was developed. Not the only reason, but certainly one of the reasons. And some of you, I'm sure most of you have probably already heard this video, especially if you've been to one of my trainings. But it's only like 45 seconds, so I'm going to show this really quick.
You know, I've seen a lot of changes in people who've been in DBT, and it's really almost impossible to describe them because the problems people come with are very different. And our goal is developing lives worth living, and that looks different in different people. My main goal for people who come into therapy is that they get out of hell. That's my first goal. And my second goal is that they stay out of hell. And this is one of the main reasons that we teach skills, because skills are aimed at helping individuals build lives that they themselves will experience as worth living. The idea is that if you can build a life that you experience as worth living, you'll keep living and you'll stay out of hell.
Okay, so that really short video, she nails a lot of really key themes that have a lot to do with suicide. So first of all, she mentioned that when people come to therapy, they come in for many different reasons. And that's really good to know, because when our clients are in their personal hell, and by the way, when they're suicidal, you know they're in their personal hell. There's many different reasons for that. It's not all the same reason, right? And it's when you're dealing with a client that's suicidal, that's one of the first things you need to know is not all people are suicidal for the same reason. And just think of borderline itself, right? Borderline itself covers many different areas, right? There's many different facets and symptoms that go into borderline. So even from a borderline perspective alone, you don't know exactly why someone might be suicidal. Okay, so keep that in mind. And she also mentioned the word hell a couple of times, right? So, one of her main goals is to get clients out of hell. And then another main goal is to keep them out of hell. Well, like I mentioned, when a client is suicidal, they're in a hell. And there's probably lots of hell before they got to that point. But then she also mentioned at the end of that clip that ultimately the whole point of DBT is to build a life that's worth living. So when a client is in suicidal mode, they're at the point in which life doesn't seem like it's worth living. And so that's really good to know this about DBT because, we usually think of DBT as just a collection of skill sets, and it certainly is. It's a entire toolbox, a tool shed of many, many, many skills. And that's actually one of the things that makes DBT very unique. It has this exclusive focus on skills work. But what's the point of all those skills? The point of all those skills is to build a life worth living. And we can't miss the forest for the trees, right? Sometimes as DBT therapists, we get so focused on all of the individual skills, right? We're focusing on all the trees, but we miss the whole point. The whole point is to use those skills to build a life worth living. In other words, DBT is not just a behavioral model, right? All the skills work, that sounds very behavioral, and it is. But DBT is just as much an existential model, right? It's behaviorism and existentialism both. So when we're working with clients, and especially when they're suicidal, we need to know, what are their goals? What are their values? What are their dreams, their aspirations, right? What gives them a sense that life can be worth living? And if we miss that, then what's the point of all the skills work, right? It's only going to be so useful. Okay, so kind of keep that in mind as we keep trucking forward here. Okay, so as we know, DBT has these different priorities. So especially if you're working with someone with borderline type of symptoms. And by the way, I'm going to be using borderline a lot as kind of shorthand for just emotional dysregulation, or just chaos of lots of things at once. So when I say borderline, don't necessarily think of necessarily meeting all of the diagnostic criteria very precisely. Just think of it more broadly as general dysregulation. So when you have a client that's dealing with borderline type of symptoms, they're not going to have just one crisis at a time, right? By definition, right? If they're somewhere on this borderline spectrum, they're going to have multiple crises. So that's why DBT gives us this framework to know what to prioritize. And these are the 4 priorities of DBT, as you guys already know. And so not surprisingly, the first priority of all is dealing with anything that's suicidal. So that's obviously very self-explanatory, because, as the saying goes, we can't help a dead client. So that's an expression that's used a lot in the substance abuse world, but it applies to mental health treatment too, right? We simply can't help someone that's already dead. So obviously, dealing with suicide needs to be top priority, first and foremost. But having said that, we can't forget the fact that these other 3 things are also priorities. So it's not like we choose one priority and neglect everything else. No, they're all priorities. This is just the order of priorities. And the reason I'm hammering that point is because when someone is at the point of being suicidal, chances are there's other issues going on in levels 2, 3, and 4, right? There might be something treatment interfering, right? Maybe they haven't showed up to their skills training group. Maybe they have been missing their sessions, or maybe there's major quality of life issues going on, right? Maybe they're getting bullied in school. Maybe they haven't been doing their skills work, right? So my point is, if we just say, oh, I'm going to focus on the suicide and then that's it, well, we might be missing out on all of these other things that are also influencing the suicidal behavior, right? So kind of keep that in mind. So when you think of these priorities, what you really want to be doing is thinking about how does all of this relate together. Okay. And yes, I fully realize I'm going to be talking really fast. And by the way, I don't know if we wanted to have a break at all, or if you guys want to just do the full 3 hours without an official break. Someone can let me know at some point. I can easily keep talking for 10 hours
Why
straight.
don't y'all, how about y'all put in the chat your preference, and then Kirby, I'll let you know what the consensus is.
Perfect. Yeah, I'm more than happy to do a break like halfway through if that would help. Okay, so since I fully realize there's a lot we can and probably should cover, what I want to do is put the most important material up front. Because everything that follows will be kind of a footnote. And if we don't get to it, it's okay. Because what I really want you guys to know is the most important stuff. Because all of, so one of the things with DBT is you learn all of these skills, and these skills are great, but DBT itself doesn't do a good job of teaching you when to use the skills. So then you're left with hundreds of skills and a client in crisis, and you're like, so where do I even start? So what I'm going to do in these next few slides is provide a framework so that you guys know what skills to use when. Right? This will be the most important part of the training. And so then all of the other DBT skills that we'll either get to or not get to, you'll be able to plug this into this general framework. Okay, so when you're dealing with a client in crisis, even if they're not in crisis, but especially if they're in crisis, it is really, really helpful to know some basic facts about how the brain works. So I learned this information when I was a very new therapist, and I've used this ever since. Every single time I deal with a client in crisis, I'm using this information. So I'm only going to focus on point number 1 here. And that is the brain develops in a very specific sequence. So the first part of the brain to develop is the survival part of the brain. So the back part of the brain. So think of fight, flight, freeze. Okay. So if you're growing up in an environment that is stable, you will have a caregiver that will help you co-regulate your survival brain. So when it gets triggered, and it will, you'll have someone that can help settle that survival brain down, right? Contain it. However, if you're going up in an environment that's chaotic and abusive, that survival brain, the fight, flight, freeze responses are being triggered all the time. Not only that, the person that's supposed to be protecting you might be actually the one that's triggering that survival brain, right? So keep that in mind. So the next part of the brain to develop is, think of the limbic system, the emotional part of the brain, kind of deep in the middle. Now, if the survival brain is stable and calm and co-regulated by an attachment figure, that's the perfect foundation for a well-developed emotion brain, right? So that's when you'll have the full spectrum of emotions, both so-called positive and negative, because trust me, we need all of them to navigate through life. But what happens if that survival brain is overactive, what happens is it overdevelops. And that's going to have a ripple effect on all of the brain development moving forward. So when you have an overactive survival brain, that directly affects the emotion brain in 2 ways. One way is positive emotions will tend to be underdeveloped. Why? Because you don't need a ton of positive emotions if you're growing up in a toxic, abusive environment. In fact, you might even learn that the emotions like love are bad, right? Like if daddy says he loves me, but then he treats me in these awful ways, then maybe love's not such a good thing. But on the other hand, negative emotions overdevelop, especially 2 in particular, fear and anger. So why is that? Well, you need fear and anger in order to implement fight, flight, freeze, right? So that's adaptive. But once again, this will have a ripple effect on subsequent brain development, because the next part of the brain to develop is the attachment brain. So this is still, if you're thinking in terms of neuroanatomy, this is still limbic system stuff. But the attachment brain also depends on previous stages of brain development. Because if you have a, stable, calm, contained survival brain, and then you have, the full spectrum of emotions, well, that's a really good foundation for strong, secure attachments. On the other hand, if your survival brain is constantly being triggered and is constantly in fight, flight, freeze mode, and you only have fear and anger to work with an emotion brain, you're not going to have secure attachments, right? You'll have every attachment style possible except for a secure attachment, right? Whether you call it avoidant, ambivalent, or fearful, or pick your term. But furthermore, if you're growing up in this kind of environment, you're going to learn that attachments aren't a good thing anyway, right? If your own caregiver is the one that's abusing you, or other people are abusing you, you'll learn to stay away from attachments. Okay, and this is important because the next and final stage of brain development is the cognition brain. So think, prefrontal cortex. So this is the part of the brain that thinks about things like cause and effect, pros and cons, short-term versus long-term, right? Think of executive functioning. This is also the part of the brain that starts to develop a roadmap, so to speak, of the world, or the self or others, right? This is how we start to develop beliefs. So once again, if we have a stable survival brain, we have the full spectrum of emotions, and we have strong, secure attachments, that's the perfect setup for a balanced thinking brain, right? That's how you're going to make, eventually learn how to make good balanced decisions, think about things like cause and effect, pros and cons. That's when you'll have an accurate or positive view of self, others, in the world. But if everything else is out of whack up to this point, the thinking brain will also be out of whack. So that's when you're going to have all kinds of thinking errors. That's when you're going to have, negative, distorted views of the self, the world, and others, etc. Impulsive decision making. Okay, so the brain develops in this specific order. Okay, and there are literally chemicals associated with these 4 different domains that I've talked about. So this isn't just theoretical. This is how the brain works. So once again, this is what happens to a brain that has been traumatized growing up. So you have fight, flight, freeze is overdeveloped, which causes positive emotions to underdevelop, which causes negative emotions to overdevelop, which causes attachments to underdevelop, which causes negative beliefs to overdevelop, which causes decision-making to underdevelop, right? So if you have some clients that feel like they are very unstable like this is why. Now, this is where I'm going with all this. Not only does the brain develop in this specific sequence, or in the case of a traumatized brain, overdevelop and underdevelop, but now this is how the brain is processing all incoming information. So this isn't just brain development. This is now how the brain is wired. And now all incoming information is jumping through the same hoops of fight, flight, and freeze, skip positive emotions, go straight to negative emotions, skip attachments, go straight to negative beliefs, skip decision making. Okay, do you see how you're going to end up with a client in crisis? Clearly. How would you not? Right? In fact, that's how you're going to end up with a client that's suicidal, right? Just think about that. Fight, flight, freeze without the positive emotions. Only the negative emotions without the attachments. And then straight to negative beliefs. Okay, if you don't understand this, it's going to be very difficult to work with a client in crisis. But once you do understand this, it is so much easier. Because what you do is you figure out, let me just go back to the slide quickly. You figure out where they're at in their brain. And that's where you meet them, and that's where you work with them. So if they're in fight, flight, freeze mode, don't be working on their beliefs. You meet them where they're at. And that's where the DBT comes in hand. So this is the framework that I really want you guys to learn, to memorize, get to the point where this is secondhand for you. and this might seem like a lot of gobbledygook right now, but let me decode some of this for you. So you might see up top, there's this, all these planets, like what in the world is going on with that? So there's a backstory here. So ever since kindergarten, my oldest boy has wanted to be an astronaut. He just graduated high school and he's now going to A&M to pursue a degree in aero engineering or something like that. So this is a career passion he never outgrew. But when he was in kindergarten, I would read kid books to him about the solar system because that's what he was interested in. And this was also the same time I was learning this brain science stuff. And what I realized, this was so fascinating. The first 5 planets after Earth directly parallel what's going on in a traumatized brain. So just hear me out on this. This will kind of give you a little bit of a word picture or a little bit of a visual so you can better understand what's going on in a traumatized brain. So Mars is the first planet after Earth. And this is what we know about Mars. Mars also has very large volcanoes. The volcano Olympus Mons is 3 times taller than Mount Everest on Earth. Mars also has a thin atmosphere. Okay, think of a client that is currently in survival brain mode, fight, flight, freeze. Okay, will there be some volcanic activity? Yes, there will. Will there be a thin atmosphere, right? Some thin skin, a hot temper, quick reactivity? Of course, they're on Mars. That's what's that just goes with the turf. Okay, so just remember, survival brain, Mars, volcanic, thin atmosphere. Well, the next brain out, or the next planet out, is Jupiter. And so what do we know about Jupiter? Jupiter has a huge storm that swirls like a hurricane. The storm itself is twice the size of Earth. Okay, so Jupiter is a very stormy planet. So even once we've helped a client stabilize that survival brain, right? That acute presentation of fight, flight, freeze, there's still going to be emotional instability there. Why? Because they're on Jupiter now. Jupiter is stormy. It just goes with the turf. It's part of the planet. The next planet out is Saturn. Saturn is the 6th planet from the sun. It has thousands of narrow rings circling it. So the rings make me think of attachments. But what kind of rings are these? The rings are made of rocks, ice, and dust, right? So just realize that even once we've stabilized a client enough to get to Saturn, right? The attachments are still going to be rocky and icy. Of course, they're on Saturn now. It goes with the turf. Don't be surprised by that. Okay, and then the next planet out is Uranus. And what do we know about this planet? Uranus is a sideways planet. It spins like all planets, but it is tilted on its side. So even once we've helped the client stabilize the survival brain, the emotion brain, and we've now reassured that we're there for them, we're trying to do our best to connect to their attachment brain. Well, they're still going to have some pretty strong thinking errors, right? Their thinking will be a little bit sideways, just like Uranus. Why does that surprise you? That's the planet they're on now. But then the next planet out is Neptune. And Neptune is much more stable than all the other planets. But this is what we read about Neptune. Neptune has storms like Jupiter's, but they are smaller. Right? So even once we help a client stabilize all of these other brain systems, right, there's still going to be some storms, but at least they'll be smaller. Okay, so kind of use this as a framework to figure out where your clients are at when they come in with a crisis. So if they're suicidal, then by definition, they're in crisis, obviously. And any client that's in crisis, what that implies is they're on Mars. That's their starting point. survival brain has been triggered. That's why they're in fight, flight, freeze. That's what a crisis is, right? No matter how you slice and dice a crisis, it's one of those responses, or all three of those responses have been triggered. Okay, so that's when you want to use some kind of distress tolerance to help their physical body stabilize. If you can't help their physical bodies to stabilize, don't bother doing anything else, right? So when they're on Mars, definitely don't pull out a think sheet and start going over thinking errors, right? Because you will literally be talking from Uranus. And they'll tell you that, right? When they're on Mars, meet them at Mars. And so that's why DBT is full of distress tolerance techniques, right? Techniques to, like, and we'll go over a few, but like, grounding with the senses, right? Self-soothing with the senses, or, the tip skill to change your temperature, different kinds of deep breathing or muscle relaxation, right? There's many ways of regrounding the physical body. That's what you do when they're on Mars. Help the body to stabilize. From there, once they're, physically less agitated, chances are their emotions are still, a roller coaster. So now that's when you use emotion regulation strategies to now help stabilize their emotions as well. And I fully get it that, there's a fine line between distress tolerance versus emotion regulation. That's why I have them lumped together. But when they're on Mars and Jupiter, that's when you're using those types of skills. My point is, you're not doing dialectical thinking stuff. You're not doing problem solving stuff. You're not doing interpersonal effectiveness stuff. Don't bother. Right? Get them stable on Mars, get them stable on Jupiter. Now, when they're physically calmer and they're emotionally calmer, that's when you zero in on the therapeutic alliance, right? That's when you really strongly emphasize the acceptance and validation. So have you been accepting and validating all along? Of course, but now they can finally hear it, right? They can't hear it when their survival brain is activated. They can't hear it when their emotion brain is hijacked, right? That's why you have to help them stabilize those first two, while being accepting and validating, of course. But now, now that those survival brain, emotion brain are a little more settled, that's when you want to really, really, really help them understand that you're in their corner, and you are going to do whatever it takes to help them get through this, right? That's when they, that's when that therapeutic alliance is very, very critically important. Okay, and only then can you help them now with Uranus and Neptune. Only then. So one of the mistakes I think we make as therapists is we too quickly move into problem solving mode, or fix it mode when the client isn't ready. And trust me, so what you do with a client that's in crisis is you take as much time as you need on each of these planets before moving on to the other one. And that might seem like it's going to be too time consuming, but trust me, this is by far the most efficient way to help a client de-escalate from a crisis. Because the more you try to rush this process, the more you're going to prolong it. Okay, so once survival brain is calm, motion brain is kind of stable, you've reinforced the attachment, the therapeutic alliance. Now the client is in a much better place to maybe think more dialectically, right? Come more to the middle, or do some basic problem solving to deal with the crisis. And of course, both you and the client are going to need to be mindful throughout this whole process, right? That's why mindfulness is at the bottom. That's the foundation. Whether you're doing distress tolerance work, emotion regulation work, validation work, dialectical thinking, problem solving, interpersonal effectiveness, it just goes with without saying that, of course, you need to be mindful. And, obviously the client is not always going to be super mindful. That's why you need to be the one that's mindful, so that you model that for them and help them with their mindfulness skills. so I know I'm packing a lot into this, but this literally is kind of the main part of the training. Because all of the other DBT skills that you guys have learned over the years, now you can plug in and now know when to use them and when not to use them, for that matter. Okay. So like I mentioned, I'm kind of using borderline just as a shorthand here to refer to just any kind of dysregulation that our clients might be experiencing. So don't overthink this. Don't be like, oh, my client doesn't, diagnostically have borderline or not. Right? Borderline is a disorder of just complete chaos and dysregulation. So, if your client is currently in chaos and currently dysregulated, think of them from a borderline perspective, right? That'll help you know what to do. And so as you guys know, if you've studied borderline before, you know that Marshall and Hand has this biosocial model, right? There's both biological factors and environmental factors that influence, emotional dysregulation. But the most important part of this whole model that I want to focus on is the invalidation piece. And you'll see why as I go through these next few slides really quickly. So I just recently came across this information, and so this really helped me understand how detrimental constant chronic invalidation really is. Because what this shows is that what most predisposes to someone developing borderline symptoms is not their biological temperament. That plays a big role for sure, but it's actually what determines borderline even more than temperament is the invalidation. So if you have, for example, a high bio risk for borderline, but low invalidation in the environment, then borderline symptoms are possible, right? You see that I have that in red. But if you flip that, if you have low biological risk, but high invalidation, your chances of getting borderline are now shifted to likely, right? So in other words, that chronic invalidation trumps even biology. And so, if we summarize someone with borderline, or a client that's in crisis, this is what you see, right? You see lots of negative emotions. You see sensitivity to triggers. And these emotions, when they do get triggered, reach higher levels, and therefore it takes longer to return to baseline. Okay, so point number 4, that's our job. When a client is in crisis, that's what we're helping them do. And if you use that model that I presented a few slides ago, this one, this will help their emotions come back to baseline much, much faster. So, especially when a client is already in crisis, 1, 2, and 3, that's already happened. There's not much we can do about that. Right now, it's our job to help them get back to that baseline. And helping them get back to the baseline is what's going to help them go from suicidal mode to more clear thinking mode. And so, obviously, you guys have all studied borderline symptoms, probably have most of this memorized. But my point here is, think of the typical student, the typical adolescent, and just think about which of these symptoms. Once again, don't think in terms of my client has borderline or not. Just think of which of these symptoms, which can happen to any of us, might be driving the suicidal behavior, right? Is it abandonment, real or imagined, right? Is it instability in relationships, right? Is it this unstable self-image? Like, I have no clue who I am. Is it just feeling empty? Is it, one of the after effects of doing one of these impulsive behaviors? And now it's all over social media. Is it just intense emotions and they're overwhelming and I don't know how to manage them? Is it anger towards self, right? Is it some paranoia? So my point here is borderline has all of these symptoms, but do you see how any of these symptoms might be behind the self-harm and or suicidal behavior? So my point is, once again, there's many different things that can lead to this point of crisis. And it's good as a therapist to try to be able to figure that out. What got them from A to Z? But the tricky part of borderline, and actually this is what makes it borderline, is borderline is highly correlated with so many other disorders. And that's part of what makes borderline is it's not just its own separate disorder. It's symptoms from many disorders that just, it's like you take symptoms from all of these disorders, put them in a blender and see what you get. And for every person, it's a unique combination of symptoms. And so it's a unique smoothie, so to speak. But once again, my point is what's going into these symptoms, right? When someone is emotionally dysregulated, they have this borderline type of presentation, they're in crisis. Is it symptoms from a substance disorder? Is it symptoms from PTSD? Is it symptoms from, right? What's driving? And the reason I'm making this point is because, and obviously you don't always know all this information unless you have, previous history with a client, but to the extent that you can, try to figure out what symptoms are driving the suicidality. Because that will once again help you know what to do with it. So, as we know, clients with, for example, mood disorders or substance disorders are much more likely to be suicidal. The correlation just kind of spikes. But you can be suicidal from any of these, from symptoms from any of these disorders. So, how you deal with someone that's coming off of a really bad trip, so to speak, is going to be different than someone that was recently traumatized, which will be different than someone that is coming off of manic this episode and now they're crashing because they stopped taking their meds, right? Do you see how all of these things could lead to a suicidal crisis? But you're gonna handle these situations differently. If they're bipolar and they stop taking their meds because they're having a great manic ride and now they're crashing, well, you're gonna make sure to get back on their meds. And if they have some kind of substance disorder and they're coming off a high and now they're crashing, well, that's good to know because you're gonna want to make sure that they stay off the street drugs, etc. So we all know about the ACEs. And so what's fascinating to me is, a lot with a lot of the ACEs, if you look at the end result, it's very linear. So the more ACEs, the more of the problematic outcome. But if you notice with attempted suicide, it's not linear. So more ACEs, certainly the adverse outcome keeps going up, but it's more of a curve. Okay, so clients with ACEs are much more vulnerable to attempted suicide. We already know that. I want to kind of come back to this whole idea of invalidation, because what we know now that we didn't know from the original ACEs study is invalidation, constant chronic invalidation. By the way, life is invalidating. We all get invalidated. We're not all constantly borderline. But when I say invalidation, what I'm referring to is constant chronic invalidation. What we know now is that is an ACE. It's not one of the 10 original ACEs, but it should be. Because what the research is, and so, the reason we know so much we started learning about invalidation is because of Marshall Linehan's biosocial model. She's the one that introduced us to invalidation as a very toxic element that causes major mental health dysfunction. We didn't know that before Marshall Linehan's biosocial model. Now we do. And now we know that even more because now there's lots of research on narcissistic abuse. So think of narcissistic abuse as extreme invalidation. It is strongly correlated with all of these things, not just borderline, right? Things that are, connected to borderline, like, mood disorders, anxiety disorders, you can see, and PTSD, you can see how that's roped into borderline, but other things that could be completely independent, such as eating disorders. So in other words, what we're realizing now is that chronic invalidation is at the root of lots of stuff. And so this one study really drives home that point. So a study of 400 who self-reported narcissistic abuse. So once again, think, chronic severe invalidation. Over 75% selected option E. So have you ever experienced any of the following? So over 75% reported experiencing either PTSD or complex PTSD. Right? So that invalidation, constant chronic invalidation, is traumatizing. That it is an ACE. And if you look at someone that's been chronically invalidated, you will literally see symptoms of PTSD. So intrusive thoughts and memories of the invalidation, re-experiencing of the invalidation, increased sensitivity to invalidation, avoidance of invalidators, right? That's the stuff of PTSD, right? So in other words, trauma is invalidating, but invalidation is traumatizing. Okay, why did I spend, 5 or 10 minutes talking about all that? Well, because I wanted to really, really drive home the point that that's why we need to be validating. We cannot turn someone in crisis around if we're not first and foremost extremely validating. And so, that's why I love how Marshall Linehan provides us with a roadmap of how to do that, how to be good validators. So, to validate a client well, obviously we first and foremost need to be present and mindful ourselves. And what I would add to that is we need to be calm and stable and grounded ourselves. Because if the client's crisis is triggering some unresolved crisis in ourselves, or some kind of imposter syndrome in which now we're freaking out, like, oh my goodness, I'm gonna mess this up, I don't know what to do. The client is gonna sense that immediately. And they'll internalize it and personalize it as something that's wrong with them. So we need to do whatever it takes professionally, personally, to learn how to be present and mindful, including and especially during the client's crisis. So that's beyond the scope of the training. I cannot help you do that or force you to do that. That's comes with time, experience, consultation. But that's really important. You get to that point where you are calm during someone else's crisis. And then validation can be as simple as reflecting back what they're saying. So reflect back verbal communication by paraphrasing, by summarizing, by asking clarifying questions, things like, did I get that right? We can also reflect back their nonverbal communication. And one of the most powerful ways of doing that is mirroring whatever nonverbal cues they're giving you. So in other words, don't just pay attention to their communication, right? Their verbal communication, also pay attention to their meta communication, right? Their communication about the communication. So if your client starts to speak faster, maybe that's your cue to also accelerate your speech, but just very subtly, right? You're not mimicking them, you're mirroring them. That's the idea behind reflecting nonverbal communication, mirror back. So if they start to speak maybe more slowly or more softly, you do the same too. If they maybe nudge forward in their seat, you do the same too. Once again, not so much that they actually notice it consciously, but they will notice it subconsciously. And at a subconscious level, that's when they'll feel like, oh, you're listening, you get it, you're connecting. And then from there, normalize, right? Normalize both what's going on in the present moment, but also the history that got them to this point. I mean, you can even say things like, yeah, I would also be thinking about taking my life if that happened to me. And then from there, demonstrate radical genuineness. So there's a few ways you can do this, right? Radical genuineness is when you are very real with your client. But obviously, you don't want to be very real without doing 1, 2, 3, 4, and 5. And by the way, it's not like you have to do all of these every single session. The idea is every time you meet with a client, and especially a client in crisis, figure out which level of validation will best meet their needs. And sometimes being present and mindful is what they need. Sometimes they just need someone to reflect back what they're saying verbally. Sometimes they need a little more mirroring than that, right? Sometimes they need someone to normalize what they're going through. But having said that, the higher up you go, what that means is you need all the prior ones. Because these kind of build on themselves. So definitely when you get to radical genuineness, you need to be present mindful, right? You need to be reflecting back, mirroring. You need to be normalizing, because those are the things that are developing trust and rapport. So when you're real, probably the best way to describe radical genuineness is, how would you interact with your own best friend? And I'm not trying to imply for a second that your client is your best friend. I'm not. But with your own best friend, you do all these other things. You're present, mindful, you reflect back, you normalize. With your best friend, you can also be their cheerleader, right? So with a client in crisis, that's when you make sure they know you are in their corner. You are going to be their biggest supporter to get them through this. That's when you also offer self-disclosure as therapy, as clinically indicated. So you might say things like, yeah, there was a time in my life when I also wondered if life was even worth it. And a lot of times, as therapists, we're a little bit nervous about self-disclosure because we think, oh, well, I need to be the professional. I need to pretend my life has been perfect. Well, that's actually very off-putting. Who's going to trust that? The more we can be real about our own lived life experiences for the client's benefit, the more the client will trust us. I'm going to skip irreverence. Let me just jump to functional validation, then I'll flip back. Functional validation is simply when we help, literally help them through the crisis, as opposed to only mirror, only reflect, only normalize. Sometimes we actually need to do something to help the client with the crisis. That's what functional validation is. We validate through our actions, not just our words. So that's when we might be not just therapist, but also case manager, right? We do something to actually help them with the situation that's been so triggering. Now, irreverence, that might seem like it doesn't apply to a client that's in a suicidal crisis situation, but it does, absolutely does. So this is a skill that it's absolutely worth your time to learn. For some therapists, it comes more naturally than others. If you just naturally have a sense of humor, this will be easier. But so, just a little bit about my background. So the last 5 years I've contracted with the government to work with asylum seekers. So these are people that are crossing the border. They're fleeing for their lives. Their lives are in complete chaos and crisis. And they're with us while their cases are being reviewed. And not everyone is granted asylum. A lot are deported. And so their lives, their futures are hanging in the balance. So as you can imagine, there's lots of mental health crises, including clients that are actively suicidal. So my rule of thumb is when I'm meeting with someone that's actively suicidal, I will meet with them for as long as it takes. And I know that's not possible in every setting. So it might be an hour, it might be 2 hours. Until I get to the point or they get to the point in which they can either smile or laugh. Because when that happens, I know they're in a completely different frame of mind. And if they don't get to that point, and sometimes that happens, then that's when they need to be referred to hospitalization. But that's what I'm looking for. And if I can use irreverence to get them to that point, then by all means I use it to get them to the point where they can either smile or laugh. So, you know, I start off every single session asking about suicidal thoughts. But that, once again, that's the population I'm working with. I'm not saying that necessarily applies to every population, but every single session I start off asking that. And especially if it's the first time I'm meeting with them, we have to do a whole mental health evaluation, and that can easily take an hour and a half. And so, you know, not only, so if it's the first time I'm meeting with them, not only do I ask them, are you currently having thoughts of hurting yourself or killing yourself? I'll also ask them questions about prior suicide history. And if they tell me, yeah, I've tried to kill myself 3 times, you know, almost always my first response is literally irreverence. I'll say, well, that clearly didn't work. And I'll say that with a smile. Or, well, clearly you failed at that. And if I get a smile back, I know that they're not currently suicidal, because I was able to use irreverence, right? Make humor of a prior suicide attempt. And if that's reciprocated with humor, right? I know the social engagement system is activated on their part. I know both of our social engagement systems are connecting, and I know they're not currently at suicide risk. So, you know, I know this rubs against our grain of, you know, how we've been taught or how we think. You know, suicide situation, it seems so serious and so heavy. But if there's anything that you can find humor in, try it. It's not to mock the client, obviously, but sometimes the dumbest humor can get them to turn the corner. Right? If you see that crack of the smile, if you see some laughter, right, you know you're dealing with a completely different person. So yeah, I would say this irreverence piece is huge. And Marsha Linehan, well, you know, obviously she's the one that created DBT. This is probably when she most used the irreverent skill, was when clients were reporting some kind of suicidality. Okay, so, you know, when a client is in crisis mode, you know, what that means by definition is something's out of whack, right? They've lost their balance. And these are all ways that our clients can get out of whack. So either over awareness or under awareness, right? Think, and I'm probably just going to use PTSD or borderline as we go through each of these, because these are really good examples of how you can get stuck at either extreme. With PTSD, you can either be hypervigilant or dissociative, right? Do you see how it's either too much awareness or not enough? You know, with borderline, you can either be overthinking or underthinking, right? Overthinking is when you're obsessing about a relationship, right? Just think of all the borderline symptoms that have to deal with relationships, right? The idealization, the devaluation, the fear of abandonment, the paranoia. What do all those have in common? It's overthinking a relationship. People with borderline are also very impulsive. They make reckless decisions. In other words, they're not thinking enough. With borderline, you can also have both emotional overwhelm or feel completely numb, right? You can either be on that roller coaster or just feel empty and dead. With borderline, you can also either be overreactive or underreactive, right? Overreactive is fight, flight. Underreactive is freeze. You can also be too aggressive or too passive, or too dependent on someone else, or think you're too independent. Okay, all of these things can lead to a suicidal crisis. So the whole point of DBT, like all of these skills that you guys have learned, is to provide a middle path. So it doesn't even matter which extreme they're stuck at. It doesn't matter. All of these extremes are problematic, right? And so that's exactly how we get these 5 skill sets. And by the way, Marshall Hand, she didn't even know necessarily, when she created borderline, she didn't even know that trauma created these specific extremes. But point for point, each of these skill sets provides a middle path, whether it's, hypervigilance and dissociation on one hand, well, mindfulness is the right balance. Whether it's overthinking or underthinking, dialectical thinking is the right balance. Whether it's emotional overwhelm or just feeling dead and numb, emotional regulation is the middle path. Whether it's overreacting or underreacting, distress tolerance is the middle path. Whether it's, too much aggression or, too much passivity or too much, I hate you, don't leave me, whatever it is, interpersonal effectiveness is the right path, right? So that's why we're using these different skill sets. We're helping them, get back on track. Because when they're on that middle path, they're no longer suicidal. When they're stuck at the extremes, that's when they're more vulnerable. So as you know already from DBT, and by the way, these are all what DBT would call dialectical dilemmas when someone's stuck at the extreme. So the main dialectic of DBT is balancing acceptance and change. So that's our dialectic that we're dealing with as therapists, right? We can't expect a client in crisis to have the right balance. That's why they're in crisis. But that's why we need to figure out, okay, in this crisis situation, how much acceptance and how much change. So obviously they need both. That's why we have this. But it's your job as a therapist to know when to up the ante on one or the other. And there's not like a clear formula to tell you how much of acceptance and how much of change. We always need both. But a really good simple formula that I learned once that I think is valuable is when in doubt, validate, 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 skill. In other words, 3 of acceptance to 1 of change. And I think that will especially apply to someone in crisis. We're not just throwing skills at them. That's not going to work. We're doing tons of validation. And along with the validation, we're weaving in skills that they need to de-escalate. And if you remember, one of the assumptions of DBT is it's much more effective to change what's driving a behavior than just to target the behavior, or certainly to judge the behavior. If judging the behavior, targeting the behavior, validating the behavior worked, well, it already would have worked by now. Because they've had plenty of people try to change their behaviors in life, and it hasn't worked. So that's why as therapists, and DBT gives us this perspective to be able to do this, it's much more effective for us to start to figure out what's feeding into the behavior. Are certain thought patterns, certain emotions, certain choices or lack of choices? Is it something that's going on in their own minds? Is it something that's going on in a relationship? Is it something that's going on in their environment? So the idea is, especially in a crisis, you're not necessarily, it might not be reasonable for a client to have insight into all of these things. After the crisis, it would be great to help a client figure out all the things happening in all these areas that drove the behavior. But you as a therapist, you definitely want to start thinking about what is going on in all these areas that's driving the suicidal preoccupation. So as you already know, DBT has these 4 different components. So especially when a client is in crisis, that's when you're dealing with these last 2, because chances are the crisis isn't occurring during your scheduled session or your scheduled group. it's probably happening outside of a formal session, in which case now you're doing crisis counseling, or in DBT terminology, it's between session support. And then, each time you deal with one of these crisis situations, especially at the level of suicidality, obviously that's when you also want to make sure you have a consultation team in place, because that's when you need to debrief. You need to debrief, right? For your own sake, emotionally, but also just for honest input and feedback. Okay. So before we jump into mindfulness, did everyone get the attachments that I emailed out? Okay.
Yeah, we should have. And also, just so you know, the consensus was a break. So I guess around 2:30.
Yeah, that's perfect. So if I forget, just please interrupt. So yeah, I just want to really briefly point out the attachments that were emailed out. So 3 of those included safety plans, and those are literally safety plans that I just ripped off of Google, like right before the training. I was like, it'd be good to have some samples. And so I picked 3 different samples. And so my point in showing you samples are just so you know what's included in different safety plans that are out there. But I can't prescribe for you guys a specific safety plan that I recommend. And the reason for that is every setting is different and every population is different. So you guys probably already have safety plans that you use. If that's the case, then use those. Use what you already have. But then I also emailed 2 different assessments, suicide assessments. And the reason I selected these 2 is simply because these are official DBT assessments. If you guys have your own assessments that you use that work for you, obviously use them. But the other reason I selected these 2 in particular is because it's very short, only 4 items. And the other is a lot longer. It's like 1, 2, 3, 4, 5, 6, 7 pages. And both have their place. But the point I want to drive home is there is a time and a place to do a really quick assessment, and there's a time and place to do a full assessment. But the reasons for doing them are different. So, like I mentioned, at the beginning of every single session, I do a quick check-in. So a quick, that's already an assessment. So are you having suicidal thoughts right now? Right? That's literally all assessment needs to be. If you need a little more, if a client is in crisis, and you need a little more than that, then what I would recommend is doing something like a 4-item assessment. That's literally empirically validated. It's been researched, been tested, been standardized, and it will even give you a quick algorithm to know what to do. So you're already doing basic documentation to protect yourself. Obviously, the main goal here is to protect the client, but as you know, we need to protect both client and ourselves. So you can literally do a quick and dirty or quick and clean assessment in 4 questions. So what happens if you do a quick screener and it turns out the client is, they're reporting active suicidal ideation? Okay, this is what I do. So I literally thank them for the information, and then I move on with the session. Literally. So, a mistake, I considered it a clinical mistake that a lot of clinicians make is they hear the initial report of suicidal ideation, they freak out, and then they do an entire session on suicide, or they might launch into a full assessment, 8-page assessment. And what you're doing that whole time is you're reinforcing the suicidality. So what I do is if there's a potential red flag, move on to the session. I'll do a full 45-minute, hour session, whatever. On whatever's going on in their life. We'll do skills work, whatever's relevant. And then I check in again. And a lot more often than not, when I proceed in that way, they're no longer suicidal. And I've done no intervention specific to suicide. But from the client's perspective, in my mind, I am, right? What I'm doing is I'm thinking about where they're at in their brain, and I'm using the session, to settle down, their physical bodies. And then from there, I'm using other interventions to calm down their emotion mind. And then of course I'm doing lots of validation to connect with their attachment brain. And then I'm helping them think dialectically. So what I'm doing is I'm using the session to help settle down, stabilize each of those parts of their brain. And a lot of times by the end of the session, they're no longer suicidal. Now, if I do a full, hour session or however long it takes, and they are still actively suicidal, well, that's now when you want to do a longer assessment. Because, one, they need it, but also you need to do really good documentation. And that's, chances are when you're going to refer out, refer for some kind of, maybe hospitalization. So that's the approach I've used, probably throughout most of my career. Absolutely, when working with the asylum seekers. Quick screener at the beginning. They're reporting some kind of suicidal ideation. I just acknowledge it, move on with the session, see how they're doing an hour or so later. Once again, if I can use some kind of intervention to help them smile, laugh, I know I'm dealing with a completely different person. And that's when, revisit the safety plan, make sure we're all good, but they're no longer in crisis mode. So what a lot of my colleagues do that work with asylum seekers is, once again, if a resident, we call them residents, comes in reporting even fleeting SI, launch into a complete 2-hour assessment. In which case, now for 2 hours, that's all they're talking about is suicide, 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 suicide. And now, of course, they're very suicidal, and now they need to be hospitalized for, sometimes, 7 days, 10 days. When all of that could have been so much more therapeutically handled if you just understand how the brain works. If they're in fight, flight, freeze mode, of course they're going to be suicidal. But you settle down those different brain networks, get them to a different place, and a lot of times, brand new client is leaving your office. Okay, so, when I just, almost from the client's perspective, nonchalantly move on to the session, I might be doing some mindfulness work. I might be doing some distress tolerance work. So I'm sure you've seen this definition of mindfulness before: paying attention for a purpose in the present without judging. So it's a great definition. It's kind of the classic definition out there. But I also think this is very idealistic and very aspirational, because when a client is actively suicidal, they're probably not doing any of this. But even if we can help them pay attention for a purpose in the present, by definition, if they're suicidal, they have tons of judgments going on. Tons. And so I would like to kind of rephrase this. Especially when you're dealing with a client actively in crisis and actively suicidal, think of mindfulness as paying attention for a purpose in the present while noticing your judgments. If you're going to wait for your clients never to judge, well, you'll never have clients. Of course they're judging. They're judging themselves. They're judging life. That's part of that's driving the suicidal crisis. So it's much more helpful for them to start to notice these judgments, as opposed to saying, well, if you have judgments, apparently you're not mindful. right? That'll just be yet another judgment to add to the list. So yeah, let go of this idea of mindfulness means without judging. I think if you're going to be a Zen Buddhist, yes, keep this definition. If you're using this for clinical purposes, a better way to think of mindfulness is paying attention for a purpose in the present while noticing your judgments. And so when I'm, working with a client in session, it helps me to realize that even in the original languages, there was 3 completely different terms and almost constructs to define mindfulness. So all of these have been kind of lumped together into our English term, mindfulness, and we kind of lose some of the original nuance. So in the original languages, one of the words used for mindfulness referred to just focusing on one thing at a time. So some kind of concentrated focus on just one thing at a time. And there's no idea or no expectation that it needs to be prolonged over time. Right? If you can just notice your breathing for 5 seconds, that's great. You're just noticing that. If you can notice how you're sweating right now, if you can notice your heartbeat, right? Just one thing at a time. That's it. Now, sometimes it's helpful to keep that focus going over time, but that was a completely different word, completely different concept, right? Learning to focus on your breathing for a full 5 minutes, or learning to pay attention to one of your 5 senses for a full, 10 minutes. Well, that's a different concept. And if a client's in crisis, maybe they're not able to do that. Well, that's fine. Let's just focus on one thing at a time, even if it's only for a few seconds. But then I love this last term that was used for mindfulness, because, and this is really where it's at anyway. This is where we're trying to get with our clients. It's awareness of the mind itself. So both when the mind is focused, but also when it's not. And so if you're working with a client and you're doing a basic mindfulness exercise, and they're like, "This is so stupid. This is not working. I'm terrible at this." What you can say is, "That's awesome. That's amazing. You're noticing what you're thinking right now. That is mindfulness." Doesn't matter if you weren't able to pay attention. You noticed that you weren't paying attention, right? That means that you're now learning how your mind works. And all of those, judgments that they're spewing out, like, "I hate this. This is terrible. I'm not good at this. I'm not good at anything." That is actually, that's how they think in general. Those are their judgments that they're applying, not just to the mindfulness exercise. That's just the opportunity to expose all of these judgments, right? Really, those are the kind of judgments that they're spewing out, almost 24/7. And so really, the whole point of mindfulness, that is the point, is to start to observe what's going on in the mind. Oh, so this is what you're thinking. This is what you're feeling. Wonderful. That's really good insight. And so, the whole reason that mindfulness works is because you're starting to observe the mind. And here's why that's such a big deal. Whatever we observe as humans, we change. So, if you walk by a classroom of rowdy students and you simply poke your head in the door, that will change their behavior immediately. Maybe only for a few seconds, but adult looking in the door, right? At least pretend I'm behaving right now. If a cop parks right next to a school, right, where the speed limit is reduced, people start to slow down just by the cop observing, right? So as humans, we change things through observation. So obviously we need to do more things than just observe to change things, but observation alone changes an awful lot. And that's what we're helping a client that's in crisis do. Just observe these emotions, observe these intense thoughts. And that literally helps start to de-escalate them. So DBT has this idea of expanding awareness. And so when we're helping a client become more mindful, what you want to do is start with the physical body. And I would say this is even more important when we're working with a client in crisis mode. Get them in touch with their physical body first and foremost, right? Because when fight, flight, freeze has been triggered, it's showing up in their physical body, right? When the survival brain is active, all fight, flight, and freeze are not passive activities. Even freeze is not a passive activity. There is tons going on chemically in the body to mobilize fight, flight, freeze. So that's going to activate their bodies. So the first thing you want to do with a client that's, triggered is get them back, get them in contact, get them grounded with their physical bodies, help them know what's going on in their physical body. And especially a client that is feeling suicidal, they're very disconnected from their body. So helping them get in touch with their physical body, whether, or even if they're self-harming, maybe they're not suicidal, but self-harming, right? So in that case, they are trying to get in contact with their body, but they're doing it in a way that's inflicting harm. So either way, get them to notice what's going on in their physical body first and foremost. And then from there, you help them figure out what's going on in their mind, right? What's going on with their thoughts, what's going on with their emotions. And then from there, you help them be more mindful of everything else that's going on in life. So let me just make sure. Yeah. Okay. So you already know these different interventions. These are just simple ways of helping clients get physically reconnected with their bodies. Could be breathing exercises, could be muscle relaxation, different movements, the 5 senses for sure, other sensations. You guys are all the experts on all of that. I'm sure you all have many activities that you use with kids, with students. And so once we've helped a client get better connected with their physical bodies, now we can help them once again be more mindful of what's going on in their minds. And once again, there's many exercises to help them with that. This could be leaves floating down a river. It could be clouds floating by in the sky. Pick your variation, pick your poison. That doesn't really matter. But the idea is help clients start to figure out, so what is going on in my mind, right? What are the different thoughts going through my mind right now? The different emotions, memories, urges, sensations, you name it. And what this exercise does is not only does it help the client start to notice these things going on psychologically, but it also starts to create a healthy distance between themselves and what's going on in their minds. So it's not dissociation. That's completely different. Dissociation is you're not mindful at all. This is mindfulness. But to be mindful, you're observing the mind itself. And so what I mean by this healthy distance is, the clinical term for that is diffusion, right? Not diffusion. That's more of a chemical term, but diffusion. Because what happens is, especially when we're crisis mode, we've become fused to our emotions, our thoughts, our urges, right? Whatever's going on in our mind, that completely defines our entire identity and our entire existence. Right? Diffusion means just some healthy distance. Like, yes, this is going on in your mind, but these are just transient events, right? They're just floating down this river. They're just clouds floating through the sky. And these are thoughts and feelings and urges we all have from time to time, but they're not you. And that's what these different exercises help the client do. Right? By sitting on the bank of the river and just observing them. It's putting it's helping the client become the observer. And these things that are going on in their mind are just things that are getting observed. And then from there, we help clients become more mindful of everything else in their life. And really, those 3 levels, right, what Marshall Linehan calls expanding awareness, that's what leads to insight. And I think that's really important, because mindfulness is not an end in and of itself. It's the means to the end, right? When we help a client become more, better grounded in their physical bodies, more aware of what's going on in their minds, more aware of what's going on in other areas of their life, now we've helped create some more insight. And so it's that expanding awareness that helps them become less suicidal in their thinking. I really like this as just a simple, what I call a mindfulness action plan or a map to help clients stay grounded in the present moment when it's very difficult to do that. You just fill in these basic prompts, right? I am here now, accepting, noticing, doing what I care about. So remember, DBT is all about building a life worth living, and that's the whole point of DBT, and that's sometimes that's the piece we sometimes forget. So we need to help clients get, use their goals, use their dreams, as that's the end. Mindfulness is just the means to get there. So the rain dance can also be really helpful with helping clients stay mindful of intense emotions and thoughts that tend to go along with suicidality. So you're not going to necessarily, if their urge to kill themselves is an urge that they're at high risk of acting on, then you might not use this, right? You might have to use acting opposite or something else from DBT. But you can absolutely use this with all of the other intense emotions or thoughts related to the suicidality, right? And if you can help decrease that intensity, the intensity of everything else, a lot of times the urge to kill themselves will also go down, right? So that's, once again, when you're doing a session with a client, you're not necessarily, even a client that's actively suicidal, you're not necessarily focusing on suicide, right? You're focusing on everything else. Remember that assumption of DBT? Instead of focusing on the behavior, focus on everything else that's driving the behavior, right? That's one of the 5 assumptions of DBT that we tend to forget. So you can, this is very typical of my sessions. I frequently focus on everything except the quote unquote problem behavior. And sometimes that even throws clients for a loop, because they're like, oh, I thought we were supposed to be talking about this. I was like, oh, we can if you want, but I thought these other things would be more interesting. And they're relieved that I'm not going to be only talking about the problem. And maybe they're even thinking, oh, I'm off the hook. When not necessarily, but really we're talking about all of the other things that feed into the problem behavior. So the rain dance, if you're not familiar with this, it's, so you recognize, the intense feeling, especially where you're feeling it physically in your body, then learn to allow it. That might help to visualize it as a wave that comes and goes. And then from there, inquire, right? Take on a posture of curiosity, instead of judgment, right? So allow it instead of fighting it, and then curiosity instead of judgment. Because when you fight an intense feeling, it only becomes more intense. When you judge an intense feeling, it only becomes more intense. Right? So that's the whole point of recognize. Now, observe. Remember, observation alone starts to change things. If you just start to observe the emotion and then allow it, give it permission. And some self-validation can be really helpful too. So there's 3 phrases, and I have a separate slide on this later on, but 3 phrases that you can teach clients for self-validation is, I am feeling XYZ. It makes sense that I'm feeling XYZ, and it's okay that I'm feeling XYZ, right? That's allowing. This is what I'm feeling. It's okay that I'm feeling this way, and it makes sense that I'm feeling that way. That will bring down the intensity of an emotion much more than trying to fight it or judge it. And inquiring is like, you can ask yourself questions like, I wonder why I am feeling this way. That's very different than, well, this is so stupid and I'm overreacting again. And then nurture is some kind of self-soothing, self-nurturing behavior. So the idea here behind the rain dance is learn to dance with these extreme, intense emotions as opposed to fighting them. And then something else we're going to absolutely want a client in crisis to do, and it is help them figure out what's going on in their thinking mind, what's going on in their feeling mind. And then from there, what would your what does your wise mind say about all that? So, three questions that a DBT therapist will ask are, what's your thinking mind telling you right now? What is your feeling mind telling you right now? And so based on that, what do you think your wise mind wants to do with all of that information? And so someone that's in crisis mode, obviously their thinking mind's out of whack. Obviously their feeling mind's out of whack. They might be overthinking. They might be underthinking. They might be overfeeling. They might be underfeeling. Chances are they might even be doing all four at once. And if you think, how is that even possible? Well, apparently you've never met someone with borderline, because someone with borderline in a crisis, they're doing all four at once. Okay, and that brings us right up to 2:30, and it's a good breaking point anyway. So how long of a break should we
I'm gonna
take?
do like 10 minutes. Is that okay?
Perfect. Yeah.
All right, so 2:40, we'll see everybody back here. All right, Kirby, whenever you're ready.
Okay. Okay, so once again, I fully realize this is kind of a whirlwind tour of DBT. So hopefully my pace is okay. I know I'm talking really fast. So we've already covered mindfulness. And remember the importance of getting the client back in contact with their bodies, in touch with whatever's going on in their minds, and then from there, everything else in their life. So now let's switch gears and we'll talk some more about, let's talk about distress tolerance and emotion regulation. And so remember, this is the whole point of distress tolerance is to help stabilize the survival part of the brain. Once that's been triggered, the fight, flight, freeze. And then when we get to emotion regulation, that'll help stabilize the limbic system. So remember from your previous DBT trainings that the whole point of DBT distress tolerance is simply to help the client not make things even worse, right? When they're in crisis mode, by definition, they're doing behaviors that are making things even worse. So we need to kind of stop the bleeding, so to speak. So you can think of distress tolerance as sort of like harm reduction. We're not trying to make anything better yet. We have to wait till the crisis is over before we get to that. We're just trying to help the client not make the crisis even worse. And so that especially applies if the client is actively suicidal. And what also especially applies if the client is actively suicidal is that the second part of distress tolerance, which is all about turning unbearable pain into bearable pain. So if they're actively suicidal, they are dealing with some kind of personal hell. Their pain is at levels that are intolerable. And so suicide is the only solution they see to stop that unbearable pain. So that's why we're using distress tolerance techniques to dial down that pain to more manageable levels. Obviously, we're not going to take away the pain, but we need to help them dial it down to the point where they're accessing their wise mind, and they can start to see other viable solutions. So what is a crisis? A crisis is basically doing any of these things that make the crisis even worse. Right. So any kind of impulsive, self-injurious, addictive, suicidal behaviors, that's just adding fuel to the fire. Right. So the whole point of distress tolerance is helping clients do other things, other kind of coping skills that are more effective. Right. So if you think about it, the impulsive behaviors, self-injurious, addictive, and suicidal behaviors are coping behaviors. They're just not effective. So the client is already trying to cope. So we need to give them credit for that. The only problem is those sorts of coping strategies, even if they provide temporary relief, are making things worse. So when a client is actively suicidal, radical acceptance is tricky. So, when a client is actively suicidal, that's not necessarily the time and place to give them a lecture on radical acceptance. But that's when you're thinking as a therapist, what are the things in their life that they're not accepting that's making this much worse? Right. So even if you're not pointing that out in the moment, you're already starting to process that on your end. So for example, are there events from their prior history that have happened to them that cannot be changed? Chances are yes. And so what you're starting to think about as a therapist is their inability to accept those things now causing them even more issues? Is that what's causing the crisis more than what actually happened? Right? Because that's the problem with non-acceptance. The non-acceptance piece causes even more issues than the actual issue. Or are there current ongoing situations that are clearly problematic, but the inability to accept it is causing even more issues than the actual issue? Right? Once again, that's the whole idea behind radical acceptance. Not that radical acceptance is easy, because it's not. But the problem is not accepting makes things even worse. Or is there something from the present that really could be changed, but the client's not accepting it? Therefore, it can't be changed, right? We can only change something that we've accepted, right? So, the lack of acceptance might be part of what's driving the crisis. So a very simple analogy that I love, and this comes straight from Buddha. So Buddha gave the example of two arrows. So basically, anything that's happens to in life that's painful is like being shot by an arrow. And trust me, we all get shot by many painful things in life. But as soon as we decide we cannot accept that, now we just got shot by another arrow, the arrow of non-acceptance. And Buddha's whole point was, look, life has enough arrows. There's plenty of arrows to go around. We don't need even more. And that's why Buddha was so intent on preaching, I guess you can use that term, this message of acceptance. Accept the first arrow so you can deal with it, so you don't need to be paralyzed by yet another arrow. So acceptance does not imply for a second that you condone or agree with or appreciate or want the first arrow. It has nothing to do with any of that. So it's, and once again, you were, this is not the time and place to, necessarily for a lecture on two arrows to your client. Like, oh, that's why you're in crisis, because you haven't accepted this and now you're dealing with that too. Trust me. But from the therapist perspective, you're starting to maybe think about, is there something in their life that they have not accepted that is driving this crisis? So a huge part of radical acceptance that I think gets overlooked is you can think of radical acceptance as self-compassion. So part of radical acceptance is treating yourself the same way you would treat a newborn baby, right? The same way you would embrace a newborn baby. So with a client that's in crisis, chances are they don't have a ton of self-compassion right now. So that's when we are the carriers of radical acceptance for them, right? We're the ones that are embracing them emotionally with the acceptance that they need. So remember, distress tolerance, and includes some skills that are very abstract, like the radical acceptance, but then it also includes many skills that are very, very tangible, very concrete. So there are ways of coping that involve the physical body, right? You can use your own physical body to cope. And the reason that's so important is because if they're in crisis mode, right? If they're in other words, fight, flight, freeze mode, their physical body has been hijacked. Therefore, it's really important to help bring some restabilization to their physical body. So these are just some simple strategies to do that. One is as simple as the open hands. And so the idea behind that is sometimes, well, our emotions and our mood and our attitude a lot of times follows our body, right? So we think of, let me just use facial expressions as an example, as a direct reflection of our mood. And that is the case. But what we don't realize is that's a two-way street. Our facial expressions also influence our mood. And that's not just our facial expressions, that's our body language too. So anything we can do with our bodies, so such as simple as opening your hands, literally helps you feel more open to life. And that's the main reason, if you think throughout human history, prayer takes on different body postures, right? It might be kneeling down, it might be raising your hands. What do all of those different body postures have in common? They're all ways of indicating surrender or openness to life. So if we can, and a client doesn't even necessarily have to know what's behind the intervention, but if we can help them take on a body posture that shows more openness, such as opening your hands, that's literally helping them become more open to life. In the half smile, once again, that's not just like a corny, cheesy DBT intervention. Especially if a client is suicidal, I'm using that as a huge litmus test for how they're doing. Because if they cannot physically produce a half smile, then I do know they're in rough shape. And I'm already anticipating some kind of referral for more intensive psychiatric treatment or stabilization. But if I can see that half smile or a full smile or a laugh, then I know that they're no longer in crisis mode. Literally, they're now activating a completely different part of the brain that's much more open to life and willing to engage with life. And then we have some of these other interventions that you're probably familiar with. So the tip skill, these are all ways of physically activating the body. So when someone's in crisis, sometimes what you need to do is mobilize the body. Sometimes what you need to do is relax the body. So that's why there's two different interventions here. One is tip the balance, the other is rest the mind. And so both of these are going to give you plenty of options to work with. So the idea behind tip the balance is, since there is such a obvious mind-body connection, and that mind-body connection is very much a two-way street, since we know that, one of the most efficient ways to shift someone's mood is to change up what's going on physically in their bodies. So sometimes as therapists, we try too hard to fight fire with fire. So if we try too hard to change someone's mood by trying to change their mood. Why? If you're dealing with this, if you're dealing with a situation that works, fine. Obviously, DBT is all about whatever works. But we all know from our own personal lives, when you're in an emotional funk, it is so hard to get out of that funk by focusing on that funk. So why do that? Chances are it'll be much more effective and efficient to just start changing up things in the body. And your mood will follow. Why? Because emotions, by definition, are a direct reflection of what's going on in the body. So change up what's going on in the body, and your emotions will follow suit. So these are 4 quick ways of doing that. One is as simple as changing up your temperature. I do that all day long. I just, during the break, I took my coffee cup to the sink, so I don't have that with me right now, but literally most of the day I have, freezing cold ice water and boiling, simmering coffee. And I sip both all day long. As soon as I get in my car, I start to adjust the temperature up and down, up and down. If I'm stuck in traffic, I turn on the AC. Just so I'm in my home office right now. So I've changed the thermostat 3 times today. Because I know how well this works. As I adjust the temperature, I am adjusting my mood. And when I'm triggered, I adjust the temperature even more. Sometimes I can't change a single thing in my life except the temperature. So intense exercise refers to, mobilizing the body. Doesn't have to necessarily mean, running through 3 marathons before noon. Just, something I did today, that was intense physical activity is I took 20 minutes to reorganize supplies in my home office. And it was a flurry of activity. Pace breathing refers to any kind of deep diaphragmatic belly breathing, controlled breathing, pick your term. And paired muscle relaxation refers to, think of it as any kind of progressive muscle relaxation. The reason Marshall and Hand is calling it paired muscle relaxation is to pair it with the breathing, right? So as you inhale, tighten your muscles. As you exhale, relax your muscles. Now, the good news about each of these 4 is you can actually do each of these 4 in isolation, right? You can do, each of these can be its own intervention, right? A specific activity, the only purpose is to change up your temperature. Specific activity, the only purpose is to mobilize your body. You could just focus on your breathing. You could just focus on your muscles. But the good news is there's lots of activities that you can do that incorporate 2, 3, or all 4, right? For me, riding my bicycle. That's the quickest way for me to change my temperature, mobilize my body, get my breathing into a rhythm, and also tighten, relax my muscles all at once. So sometimes that's what you're going to need to do with a client in crisis. 1, 2, 3, 4 of these. Find ways to tip the balance. You will get so much more out of that than trying to talk them out of suicide, or trying to pull out a think sheet, right? Trying to talk from Uranus when they're still on Mars or Jupiter. Okay, and sometimes what clients need is not more activation, but less. So when that's the case, what you can do, what's called restrictive environmental stimulation therapy. Just a fancy way of saying, okay, how can we reduce as much stimulation as possible in the 5 senses? But once again, why? Because of the mind-body connection. If we can reduce stimulation as much as possible in all of the 5 senses, then that's less activity for the mind. Because what is one of the main functions of the mind? It's to process everything coming into the 5 senses. But sometimes, back to the 5 senses, sometimes that can also be a really good distraction. Okay, so do you see the art and science of DBT? And this is why DBT can be overwhelming and confusing for therapists. There's all these skills that seem like they're contradictory, and they kind of are. That's because as humans, we're very complex. Sometimes we need less stimulation. Sometimes we need a good distraction. So that's your job. That's based on your own clinical intuition, right? Once you know all the skills, the tricky part then is figuring out which skill will be the best for a client in this situation. And don't necessarily think it's pass or fail, right? It's try this. If that doesn't work, try something else. So yeah, helping clients engage the 5 senses in a way that's calming, soothing, and grounding can also be very effective. But the key here is not everything a client looks at, listens to, smells, tastes, or touch will have a calming effect. If it's going to be something that hijacks them even more, well, that's not something you do. Right? So the key is something that will ground them, calm them, soothe them. Okay. And then I really like this intervention. This is very effective. So the idea is as you help your client do whatever kind of breathing exercise you normally do, you simply, in addition to whatever the breathing exercise entails, also have them focus on their heart or their chest area as they do the breathing exercise. And literally, this is too good to be true, literally more oxygen will come to the heart. And the reason that's so important is because the heart is surrounded by the lungs. Those two organs have tremendous influence on each other. The heart is the first organ to receive oxygen from the lungs. The lungs is the first organ to receive blood from the heart. So whatever's going on in those two organs affects each other. So as you're doing the breathing, but consciously, intentionally focusing on the heart, more oxygen comes to the heart. The heart is also a really, really good sensory organ. It has really good sensors. It's constantly monitoring oxygen levels. And when the heart realizes, oh, there's plenty of oxygen, it chills, it relaxes. When the heart realizes there's not enough oxygen, that's when it freaks out and it panics. Because from the heart's perspective, if there's not a lot of oxygen, I need to pump even faster and get the little bit of oxygen we have, to as many body systems as possible. And then that just puts every body system on high alert, especially the brain. Whereas when the brain detects high oxygen levels, it realizes, oh, we're good, plenty of oxygen. And that has a calming effect on the lungs, has a calming effect on the brain, has a calming effect on everything. So very simple intervention. And once you learn this intervention, there's all of these other interventions you can pile on. So for example, as you're doing your heart focused breathing, maybe also think about your favorite experience. So favorite memory, favorite hobby or something. And do both at the same time. Heart focused breathing, visualize this positive experience. And of course, as you visualize a positive experience, eventually you're going to pull up some kind of positive emotion. So eventually you want to be able to do this, the heart focused breathing, with just in conjunction with the positive emotion. And if you have to, visualize the experience first to get there, no problem. But the idea here is have the heart focused breathing now paired with, associated with that positive emotion. So every time you do the heart focused breathing, now your brain has learned, oh, it's time for this positive emotion. And then what you can do is you can help the client radiate that positive emotion, maybe, have it project towards a mirror and then reflect back. And if that's too difficult, maybe radiate it towards the person you love first, practice that, and then make yourself that person you love. Right. And so, when a client is actively suicidal, it's probably not the time and place to teach them this for the first time. But if they already know this, when a client is in crisis, this is a great intervention to use. Right? We're going to do some heart focused breathing right now. Okay. And as you already know, DBT has all of these distraction skills. So these are not dissociation skills. They're distraction skills. So from a DBT perspective, you're still helping the client be mindful. You're just helping them be mindful of something else. And the idea is if we can help a client become mindful of any of these things, it's a really good deflection away from the crisis situation. So there's certain activities that they can do than just because they're in the zone. They don't even have to try to be mindful, right? They just are. Yeah, so some of these are tricky. I know when I do a full training, I talk through all of these in a lot more detail. For a school student, adolescent, the contributing skill is probably not going to be your go-to option. Comparisons might not be either. But I would say, yeah, the go-tos for the population you guys work with, probably activities, sensations, right? Use intense sensations as a distraction. Maybe other thoughts. If you can get a conversation going about something that they're passionate about. If you're going to use emotions as a distraction, this is what I recommend. Well, so curiosity, humor, and empathy are literally neurologically incompatible with fear and anger. But I would say with the population you're working with, shoot for humor. And this goes back to clinical. Remember the irreverent skill? It's one of the forms of radical genuineness. If you know how to be humorous with a client that's even in crisis and even in a suicidal crisis, you have no idea the leverage you can get out of that. I mean, that's worth hours of therapy. So for some therapists, that will just come naturally. Other therapists, you might be a little more hesitant on that. But I mean, there's a reason this is in DBT. Because here, I'm glad I have this slide here. So literally when the brain and laughter, when you are laughing, when you're engaged in some kind of humor, you are literally activating every single positive neurotransmitter that we have. So that includes serotonin, dopamine, oxytocin, and endorphins. I mean, trust me, there's no psychotropic med on the market that's even close to that. Yeah, so if you're going to use emotions as a distraction for the other intense emotions that they're experiencing in the moment, I would use humor. Pushing away could also work. If you can help a client realize, okay, we can't solve every aspect of this crisis right now. Can we push this away until we can get to some of these other details? But once again, the beauty of DBT is there's plenty of options to work with. So here are some more classic DBT distress tolerance skills. So once again, with the population you're working with, some of these probably won't be your go-to. The meaning skill will probably be outside the reach of your clients. It's probably not the time and place to reflect on. So what can you learn from this experience? I would say one thing at a time would be a good go-to. Mini vacation would be a good go-to. Relaxation. So obviously relaxation is not just saying, dude, just chill. Relaxation is helping them do something that will automatically trigger the parasympathetic nervous system, right? We have sympathetic nervous system, which mobilizes us. Parasympathetic nervous system, which relaxes us. So doing some kind of activity that will automatically trigger the parasympathetic nervous system. So therefore, they don't have to work at relaxing. I know that's kind of an oxymoron anyway. It's more doing something that will trigger that part of the nervous system, and then you'll just inherently relax from there. Imagery can go a long ways with some people, not everyone. So once again, we have a menu of options to choose from. If something doesn't work for you, it doesn't work for your client, well, that's fine. Pick something else. So think of encouragement as self-validation. So obviously, if a client is in crisis, we're also doing lots of validating. They desperately need it. Remember, I had like 5 slides on why we need to be really good at validating. But the reality is they also need to learn to validate themselves. So that's why I mentioned these 3 prompts earlier on in the training. So I feel this emotion. It's okay that I feel this. It makes sense that I feel this. I've had a chance to use this on myself recently within the last couple of weeks, and I was amazed at how well it worked. I was dealing with some intense anger, and then I had some judgments going along with the anger, including self-judgments, and I had to remind myself, I am feeling angry. It's okay that I feel angry. It makes sense that I feel angry. So riding the wave or urge surfing is another classic DBT intervention. But once again, so a point I made earlier is, oh yeah, when we did the rain dance, is you're going to need to figure out which intensive feelings to use this with and which not. Some intense emotions or urges are they're, even though they're intense, they're low enough intensity that you can ride out the wave. Other waves are more like tsunamis, and ain't nobody gonna ride that wave. If a client is actively suicidal, maybe that suicidal urge is not, maybe that's more like a tsunami. In which case, don't even bother trying to help them ride out that. That's where other skills will come in, like the acting opposite. That will help a lot more. But like I mentioned when we talked about the rain dance, is maybe there's lots of other intense emotions or feelings or urges that they can ride the wave with. And then that in turn will make the tsunami a little less intimidating, a little less overwhelming. So yeah, you as the therapist figure out which of these waves can they ride out. But don't try to force them to ride out a wave that really is a tsunami for them. Okay, and then as we all know, these are 4 conditions that make people more vulnerable to a crisis in the first place. So if a client is, in crisis and they're suicidal and they're also hungry, angry, lonely, tired, so which of these things can we help take care of? Which will, if we address some of those needs, that will do a lot to decrease this intensity of the crisis situation. Okay, so these are just, when I teach DBT to clients, I actually do not use all of Marshall and Hand's acronyms. In fact, from distress tolerance, the only one I use is TIP. I don't use improve. I don't use accepts. That's completely fine if you do. I do, a lot of my sessions in Spanish, so there's no way I can be using these acronyms anyway. What I do is I just teach different skills. And so there's plenty to choose from. And once again, everything in distress tolerance, the whole point of this is to help stabilize that survival part of the brain. And so, obviously when the client is actively suicidal, that's not the time and place to start working on a coping card. They need it. Ideally you want to have this in place before the crisis. If they don't have one, maybe you've never met with them before, maybe this is the first encounter you have with them, then wait till the crisis is over, then come up with a coping card. And you definitely want to have a coping card in place before you have a safety plan in place, because one of the main things that probably every safety plan asks for is, what are your coping skills? Well, how are they going to know their coping skills if you haven't talked about these different things? Okay. So we still have a few more skill sets to get through, and hopefully we will. Not gonna make any promises. But emotion regulation is pretty straightforward. So lots of overlap between distress tolerance and emotion regulation. The main difference from a DBT perspective is distress tolerance by definition is short-term coping in the moment so that we don't make, bad situation even worse. It's not necessarily about any long-term change. That's what emotion regulation by definition is about. So distress tolerance short-term, emotion regulation long-term. Okay, that's just a Marshall and Hand distinction. Don't lose any sleep over it. But the whole point of DBT emotion regulation is to help clients have an entire lifestyle change that will support healthier emotions. So a lot of what goes into emotion regulation at first blush doesn't really seem like it has anything to do with emotions. But these are all ways to support healthier emotions. And so those of you that have been to my trainings before know I use a garden analogy. So the idea is the same way we would take care of a garden, say a garden of flowers, is how we need to take care of our emotions. So, it wouldn't make any sense to yell at your flowers, scream at your flowers, shame, blame, humiliate your flowers, guilt trip them. Wouldn't make any sense to bury them, right? They don't need any of those things. Wouldn't make any sense to try to control them. What they need is to be cared for, nurtured, nourished. It's the same with our emotions, right? There's ways to take care of our emotions. One is obviously, well, with a real garden, you need to plant the right seeds, right? If you want a garden of vegetables, then do not, or if you want a garden of flowers, then do not plant vegetables. With your emotions, the way to plant the right seeds is to take care of your physical body. So if a client is, once again, because of that mind-body connection, right? One of the main purposes of emotions is to provide a shorthand summary of what's going on in the body. So if your body systems are out of whack, then of course your emotions will be out of whack. They're supposed to be. That's their job. And so if a client is in crisis, it can be really helpful to figure out, is something out of whack in these areas? Symptoms, exercise, eating, drugs, sleep. When they're in crisis, that's not the time and place to give them a lecture on these areas. But this will help you. This will give you a really good summary of what's going on in their life. So with a lot of my clients, that's the first thing I do in session. I have them give me a seeds report, and we just do a run through of these. And I tell clients, there's no such thing as a bad seeds report. If you can give me a seeds report, it's a good one, because it's showing that you're starting to pay attention to these things. And sometimes the seeds report becomes a whole session, in which case it's a good session, because there's probably lots going on in these areas that we need to talk about. And so, a lot of emotion regulation, you're not necessarily dealing with in the crisis itself. These are things that's more the distress tolerance. The emotion regulation is after the crisis. What are some lifestyle changes that we can implement so that you don't keep getting back into this crisis situation? So, after the crisis, you might want to provide lots of psychoeducation on why we have emotions in the first place, and why we need to listen to our emotions. Because, pain, for example, the whole point of pain is to get your attention. The whole point of emotions is to communicate to you. So put those two together. The whole point of painful emotions is there's something you really need to know. And, by the time someone gets to a suicidal crisis, they've probably had lots of painful emotions that they weren't listening to. So how can we, how can you have a different relationship with your emotions? So that you don't have to get to this point. Okay. So this can be something that you do in the crisis, to help de-escalate a crisis situation. But remember the brain systems. Remember those 5 planets: Mars, Jupiter, Saturn, Uranus, Neptune. This isn't the first thing you're doing, right? If they're on Mars because the survival brain has been hijacked, or they're on Jupiter because their limbic system is still hijacked, you're not doing this, right? You're stabilizing those others, the fight, flight, freeze system. You're stabilizing the limbic system. You're reassuring them you're reinforcing their attachment brain through the therapeutic alliance. And then once they've reached a level of stability, now you can talk about thinking. Now you can do problem solving. But before that, this kind of fact checking it's not going to work. Trust me. In my fuller, 2, 3, 4-day trainings, I go through this in a lot more detail. But this can be a really good way for clients to make sure that they're grounded in the right information. Because part of the crisis probably happens because they were responding to inaccurate information, or exaggerated information, or missing information. Right. So, in a real garden, we need to plant the right seeds. We need to do some weeding. We need to check the soil. We also need to do some pest control, because the threats to a garden are not just in the garden, like the weeds. They're also external. And so this is when we do problem solving with a client. Once again, this can happen during the actual crisis session, but this isn't the first thing you do, right? This is when they're no longer on Mars, they're no longer on Jupiter, they're no longer on Saturn. Right now they're on Uranus or Neptune. Right now, and so if you think about it, suicide from the client's perspective, at this particular moment in their life, is the solution to the problem. That's the only solution they can come up with. So that's why at some point it's really important to do something of this nature, to help them realize, okay, there are other solutions too. Yes, suicide is one solution, but it's also a solution that's going to cause many other problems for many other people. But there's other solutions too. And so that's when you're going to want to do this 10-step sequence. And once again, when I do the fuller training, I go through this in a lot more detail. And if we have time at the end, and if you want me to go over any of these interventions in more detail, I'd be more than happy to. Okay. And so another classic emotion regulation intervention is called acting opposite, or opposite action. I prefer the term acting opposite because I like to tell clients, this is just an act, right? Fake it till you make it. It doesn't have to feel real or authentic. So, if we continue the garden analogy, there's going to come a time where you're just sick of taking care of a garden. You want to do something else. You'd rather go fishing or whatever. Or maybe you might just want to burn it to the ground. And that's when you need to act opposite and take care of the garden anyway. It's the same with your garden of emotions, right? There'll come a time when you don't give a rip, and you're sick of using skills, and you would rather just do whatever you want. And that's when people can spiral out of control. So the more you have a trigger emotion, the more you have certain problem urges. The more you act on those urges, the more the emotion escalates, and then the more the urge escalates. And so with some of my clients, I call that the stupid cycle. It's an example of irreverence. I'm not calling the client stupid. We all get stuck in this vortex. I get stuck in this vortex. There are times when I'm like, I'm sick of using skills. I'm not going to use my skills. I don't care how this turns out. I'm just going to do whatever I want. Of course, I regret it every time I do that. But that's the stupid cycle. Now, the stupid cycle can be dangerous when it's the suicide cycle, right? When you have trigger emotions and the problem urge is kill myself. And the more you think about that, and the more you obsess about that, right, the more that triggers the triggering emotions, right? And this can absolutely be literally lethal. So that's where acting opposite behaviors are critical. So remember I said some urges you can just surf them. Urge surfing, ride the wave, not necessarily a suicidal urge, right? That's more like a tsunami. That's when we do acting opposite. And there's many ways that clients can act opposite. So they can literally do the opposite what they feel like doing. They can use opposite body postures. You can use the opposite temperature. That's what I do a lot. You can visualize the opposite. Say the opposite words of what you feel like saying. We already talked about opposite emotions. So like curiosity, humor, empathy are literally incompatible, neurologically incompatible with fear and anger. So once again, the idea here is for emotions that they can't just write out, those are probably things that they need to act opposite to. And then another really big part of emotion regulation is basic maintenance work. So once again, with the real garden, you're gonna need to fertilize. So this is how we fertilize emotions. And this is something we can help a client with, even starting in the crisis session. So if they're suicidal, they probably feel like there's nothing positive in their lives at all. And from their perspective, that is their reality. So that's when you start helping them add positives. And the key to fertilizing with these, emotional chemicals, so to speak, is to do this every single day. We can do all the CBT in the world to someone, but if there's not something in their life that feels positive, they're not going to feel positive. So we need to literally help them get in touch with positive experiences. And if someone is actively suicidal, by definition, what that means is that they're at a place of learned helplessness or a place of inefficacy. Or you can also say complete external locus of control, right? They feel like there's nothing they can do to make things better. So in other words, another way of thinking of that is low self-efficacy, low internal locus of control. So what we need to help clients start to do immediately is build mastery. In other words, and this doesn't necessarily have to have anything to do with the actual situation, but just get them to start doing things that foster a sense of self-efficacy, internal locus of control. Like, I can do this and it has this effect, right? So anything that can help a client start to feel more productive, more constructive. So just a really quick example of this. So I just last week started doing some remote sessions with 2 adolescents that were adopted from Africa. They're attending a school system that, for whatever reason, is extremely racially provocative to students, or just awful. So there's been some fights. But both of these boys are twins. They're on the football team. They love football. That's their world. So I am fostering that. That's their one area where they feel competent, confident. And so my goal with them is going to be to help them use whatever they've learned from football and start to translate that to other areas of their life. And the cope ahead skill is all about not just coping in the crisis, but how can we start coping every single day so that we're not back in crisis once a month or whatever. And then the D, so A, B, and C is original Marshall and Hand DBT, but I felt like, man, the whole point of DBT is to build a life worth living. So I figured there needs to be a D here. Do something meaningful. So, and once again, right starting in that crisis session, you want to help a client get in touch with what are their values, what are their goals, what are their dreams, their aspirations, and that's what needs to be the focus. And then every single day, do something that's consistent with those goals, those values, those dreams, something that's helping you make progress towards them. And that's when you might need to break down some of those goals and dreams and make them a little more specific, manageable, or measurable, attainable, relevant, time-based. Okay. So I just want to briefly mention 2 emotion regulation interventions that I really like for children. We'll start with what's on your plate. So you can, take a paper plate and help clients draw out everything in their life that's on their plate and all the things that are stressing them out. And this is basically the kid version of problem solving. And from there, you have a discussion on, okay, so what in this plate, what can you take off your plate? What can't you take off your plate? What's on your plate that you can reduce? What's on your plate that maybe someone else can help you with so that you don't have to worry about all this on your plate, etc. And then you just, keep drawing a new plate until it's more manageable. And the die game I also really like. So you pick any emotion that's, part of this crisis. And you have them show you the different, so if it's a die of 6, you have them show you the intensity for each level. So if 1, 2, 3, 4, 5, and 6, and you throw the die and you have them produce a level 5 or level 3 or level whatever. So that's helping them with two things. One, it's helping them better understand experientially what it feels like to be at these different levels. If they're currently in crisis, they're clearly at a 6. But what does it feel like? But they didn't go from 0 to 6. They went, so what does it feel like to be at a 2? What does it feel like to be at a 4? But then that's also literally helping them in real time manage their own levels of intensity. So you can be at a 5, but then you can also shift to a 3. How did you do that? Okay, so dialectical thinking, and then the last skill set, interpersonal effectiveness. Once again, these aren't the first things you're doing when they're coming in with a suicidal crisis. You're doing the other interventions first, right? The mindfulness practice, the stress tolerance, maybe some emotional regulation. Right, it takes a while to settle down the survival brain, and then the emotion brain, and then the attachment brain. Now they can think about thinking. So, dialectical thinking is all about this ability to let go of the extremes, start to see things from different perspectives, someone else's perspective, but also different perspectives in your own head, learning to come more to the middle. So if you think about it, someone that's actively suicidal, talk about a lack of dialectics, right? That's literally all or nothing, life or death. Yeah, and actually, let me just go way back. Sorry if that's giving you a headache. One of the major insights that Marshall Linehan had about mental illness was she realized that mental illness itself was a breakdown of dialectics. And that's what, I gave you these 5 examples. Talk about being suicidal. That's a huge breakdown in dialectics. So, of course we want to help them come more to the middle. But the timing is key. Because otherwise, once again, you're talking from Uranus when they're on Mars or they're on Jupiter, right? You're communicating from different planets. It's not going to work. So I really like this story that helps clients better understand this idea of dialectics. So I'll just do the Cliff Notes version of this. So there was a farmer. He had a loyal workhorse. One day the workhorse ran away. All of the villagers came running up to the farmer and they said, "Oh, this is very, very bad luck." The farmer just shrugged, said maybe. And then once you know it, the workhorse actually wandered back a couple weeks later with 50 wild horses. So all the villagers came running back and said, "Wow, this is very, very good luck," because he just, made a fortune. And then his son was out domesticating one of these horses one day, fell off, broke his leg. All the villagers came running back, said, "This is very, very bad luck," because, it was his son. He's the heir to the farm. But then once you know it, a few weeks later, war broke out in the region and all of the young men were conscripted into the battle to fight for the king. And a lot of these young men were killed. But of course, who was spared because he didn't even go to the battle? Well, the farmer's son, because he had a broken leg, right? And the story goes on and on. The point is, for the villagers, everything was either very, very good, very, very bad. Whereas the farmer, for him, he just rolled with life. The farmer was dialectical. The villages were not. The farmer saw the potential good, potential bad in every situation. So, when our clients are suicidal, they're more than the villagers. But the idea is to eventually get them to the point of being more like the farmer. And once again, you're not necessarily giving them this lecture the first session. But over time, you're helping them realize we need to be more like the farmer. A very simple visual you can provide is, we can either be like the palm tree that flexes with the storm or the oak tree that just snaps. If a client is at the point of, being suicidal, they're very close to being the oak tree. And so obviously you recognize all of these thinking errors. But what I simply want to point out is, do you see how a lot of these thinking errors can directly feed into the suicidal crisis? Or at least be correlated with it. Like certainly the all or nothing, the overgeneralization, overgeneralizing, the mental filter, disqualifying the positives, making assumptions could play into it, the magnifying, catastrophizing for sure, the emotional reasoning, maybe lots of shooting, maybe labeling, maybe personalizing. Chances are there's lots of thinking errors. So your goal is not necessarily to, CBT all of these thinking errors out of them, especially in the crisis situation, but maybe just start to notice them and just maybe tuck them away and realize at some point, at some point in therapy, we're going to have to address some of these thinking errors. Now, so, the client might have these thinking errors at baseline, and maybe that's why part of what got them into this crisis situation. But we also have to realize that when we're in a crisis situation, by definition, we're going to have these thinking errors. Does that make sense? Well, because when our emotions are, because our thinking mind influences our feeling mind, but our feeling mind also influences our thinking mind. And if our limbic system is hijacked, well, our thinking mind goes right with it. And that's precisely why when someone is actively in crisis, that's not the time to do CBT. That's not the time to pull out the think sheet. If you've been able to help them become stable enough in that same session, and now they can start to recognize some of these thinking errors, great. But don't necessarily bank on that. And here's some other thinking errors. By the way, I like to call these automatic negative thoughts for a couple reasons. One, because it abbreviates nicely as ants. But also it's a little less pejorative sounding than thinking errors or stinking thinking, or a lot of the terms that go along with CBT. And by the way, I have nothing against CBT. Just realize there's a time and place for it. And when someone's actively in crisis, it might not be the time or place. But also based on everything we've covered so far, remember, chronic invalidation is an ACE. And chronic invalidation causes so many psychiatric symptoms. And when a client is actively in crisis, and if we start using lots of CBT terminology, like that's irrational, that's illogical, it doesn't make any sense, there's no evidence for that. Do you see how that's yet another voice of invalidation? And that's not going to help the crisis. So, by using the term ants, what I do is I normalize it. I say, we all have ants. I have ants. We all have these negative, automatic negative thoughts. So the key is, to recognize them. And these so someone that's been traumatized tends to have these specific ants. So the good news is, I already said that when someone's actively in crisis, this might not be the time and place to CBT them. And the good news is you don't have to. You don't have to point out that's irrational, it's illogical, that doesn't make any sense, there's no evidence for that. DBT has a much more efficient and effective strategy than that. And for the simple reason that regardless of what kind of thinking they have, what these all have in common is these are all a breakdown in dialectics. So if that's the case, what do you need to do with them? Regardless of the thinking error, what you need to do is restore dialectics. And so a very simple way of doing that is helping them identify their extreme thought. And from there, simply ask, what's the complete opposite of that? And from there, what's something more in the middle? And this can work like magic. Because they don't have to believe the middle thought. At first, this is simply a theoretical exercise. What's the thought? By the way, you don't need to do a ton of psychoanalysis. Whatever they're saying is what they're thinking. So what's the thought? Okay, what's the complete opposite of that? And then just for the sake of argument, what's something more in the middle? Now, here's the beauty of this. If they're the ones that come up with the middle thought, then part of them does believe it because those words came from their brain. They produced those words. If you provide the middle thought for them, they don't need to take ownership of it. Well, that's just what you believe. And what do you know? You're just a dumb therapist. You've never been through what I've been through, right? There's no ownership there. But if they're the ones that come up with the middle thought, even if they tell you that they don't believe it, well, that came from their brain. But furthermore, they don't have to fully believe it. Because even if they believe more of the original thought, now you have just helped them plant the seeds for a middle thought. That means there's two thoughts in competition, which means they now have what's called cognitive dissonance. Or from a motivational interviewing perspective, ambivalence. And we know that cognitive dissonance and ambivalence are highly motivating because we don't like to have two different beliefs at once. So therefore, something's got to shift. So therefore, it's not your job to make them believe the middle thought. It's just to kind of plant that seed. And if you can, the client's middle thought is not always as dead center as you would like. Doesn't matter. Doesn't have to be your dead center. If they can come up with any middle thought, that's already dialectics. Because the whole point of dialectics is to help them see something from a different perspective. And, if they're suicidal and they come up with any other perspective, that's huge progress. So if we can, even if we're only nudging them a few degrees away from the original thought, that's already progress. And if they're actually stable enough to use the thinking part of the brain and to think about their thinking and be metacognitive and all that, then you might even want to try a think sheet, such as this one. But once again, if they're not there, you're better off doing the tip skill or something else. And so here are some more techniques that are interventions I really like to help clients be more dialectical. So for this whirlwind training, I'm only going to focus on the bottom two. So I really like fortunately, unfortunately exercise for kids. You can also use this for adults. But with kids, you can do this as a complete made up fairy tale story. And what you do is you and the client take turns. So one of you introduces a topic. Once upon a time, XYZ. And fortunately, this happened. And let's assume it's the client that says, no, it's you as a therapist says, fortunately, this happened. And it's the client that says, but unfortunately, that happened. And especially if they're in crisis mode, they'll be really good at coming up with the unfortunately. But then you follow, but fortunately, that happened. And they'll say, but unfortunately, this happened. But then you say, fortunately, this happened. And you go back and forth, back and forth, back and forth. And if you're the one saying, fortunately, you're the one that can finally end the story. Fortunately, this happened. And what you've just done is you've just taught them dialectics. Because for everything unfortunate that happened in the story, you were able to show, but then something fortunate did happen. And so, especially with kids process symbolically. So even though this was a completely made up fairy tale, trust me, every detail in that fairy tale symbolically represents some kind of psychological conflict in their life. And then what you can do is swap roles. So now, you're the one that says, unfortunately, unfortunately, unfortunately. And now the client is, forced to be the one to say, fortunately, fortunately, fortunately. So do you see how now they're the ones that are practicing dialectics? When you're the one that's saying, fortunately, 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 you're modeling it for them. Now the ones that are actually doing it. And so once again, this is just a way for clients to start to see in life, there's good and there's bad. There's good and there's bad. When they're suicidal, all they can see is the bad, 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 right? Because of the mental filter. Another intervention you can use to help clients be more dialectical is what I call play your DS, right? A DS has a dual screen. And sometimes that's why it's called DS. And sometimes what our clients need is another screen, right? They're only focusing on one screen, the negative screen, and they're missing out on another screen. So that's why what I call dialectical synonyms can be really helpful. And that is, whatever a client is, however they're describing the crisis, pay attention to all of the negative sounding words. And then, as a way to reframe it, help them narrate the same crisis. So it's the same facts, right? This isn't positive thinking. This isn't embellishing. It's the same story. You're just helping them use words that have a positive connotation instead of negative. And that provides a different screen. Now they have two screens. So on this slide, I just have examples of, on the left-hand side, words that sound negative. On the right-hand side, words that sound positive. But if you notice, they both mean the same thing. And this is just a sample. English is full of this. You can say a sentence with 10 negative words and it sounds terrible. You can say the same sentence with 10 positive words, say the same thing. Now it sounds so much better. And now you take your pick. You can look at it this way, you can look at it that way. So it's just a quick way of shifting someone's perspective. Okay. And so last few minutes we'll talk about interpersonal effectiveness. So this is what you would use if part of the client's crisis is dealing with other people. It might not be. But once again, just remember, I'm gonna hold it off. I printed out this slide. Remember, you're always referring back to this when you're dealing with a crisis. They have to be very stable for you to start talking about relationships. And figuring out what to do with a relationship, right? That's Neptune. That's when everything else is stable. That's when survival mind is stable. Survival brain is stable. The emotion mind is stable. Attachment brain is stable. And now they can think more in the middle. They can be dialectical. Now they can start to figure out something going on with the relationship. So this just gives them tools to use if the crisis involves some kind of relationship issue. So I'm sure you've heard the dear man from DBT. I call it the dear adult for a few reasons. One reason being, sometimes the reason for a crisis for a female is something that was perpetrated by a male. In which case, I'm not going to help them learn to be more assertive by teaching them dear man. To me, that's just clinically egregious. So I call it dear adult instead. But I have, I have different variations of this to fit different situations. Sometimes clients need to assert. Sometimes maybe asserting is too strong. Maybe they need to ask. But maybe asking won't be enough. Maybe they need to assert. And once again, you're helping them with that. Maybe a client needs to better appreciate someone else's crisis perspective, in which case they need to appreciate. Sometimes part of the crisis is, maybe they don't need to do this right this second, but maybe they also need to apologize to other people. So regardless, this dear adult skill helps them with all of those. So just really, really quickly, what we help a client do, first of all, is describe the situation, just the facts. This is what happened, X, Y, Z. And truly describe the situation, not the other person. If you make it about the other person, it's not going to work, right? Describe the situation. And then from there, express how you feel about the situation. Or if you want to be really dialectical, also empathize with how the other person probably feels. And then from there, you help the client ask or assert or appreciate or apologize as necessary. Maybe all four, maybe just one, maybe two or three. And then from there, reinforce. And what you're really helping the client reinforce is the relationship itself. The way you reinforce a relationship is by explaining that what you're asking for, or asserting, or appreciating, or apologizing is not just for my benefit, it's also for yours, and it's for the benefit of the relationship. Because the whole reason I'm asking, asserting, appreciating, or apologizing is because there's something in this relationship that I need. So of course I want what's best for the relationship. But something else you can help a client with, especially when they're in crisis mode, is the dear self. And I think that's one of the missing pieces in DBT. You know, there's so much focus on what to do to improve a relationship, but you are 50% of the relationship. So this can also be used as a tool to even process a crisis. So instead of the dear, by the way, the adult piece of this, I should probably briefly explain that, is all about the delivery. So describe, express, then the A, which stands for all of these, and then the reinforce. That's kind of the sequence. That's what you talk about. But the adult voice is how you say it. So that's the middle path between parent voice, which is, you know, yell, scream, throw a, give a long angry lecture. It's the middle path between the parent voice, that extreme, and also the other extreme, which is the child voice, which is, to whine, pout, and throw a temper tantrum. Neither approach is effective, whether it's the parent voice or the child voice. And I fully realize in this scheme, both parents and kids get a bad rap. But the most effective delivery by far is the adult voice, which is cool, calm, collected. Okay, but we can also help a client apply all of that to themselves. So describe the situation. What was the chronology of what happened? And especially, what did I notice through my five senses? What did I notice in my body? And then express and empathize to yourself. Like, this is what I was feeling emotionally. Wow, that was really difficult to feel all of that emotionally. And then help the client assert, ask, appreciate, or apologize to themselves. So in this case, apology isn't necessarily apologizing for something they did wrong if they didn't do anything wrong. But instead, I am so sorry you had to go through that. But I really appreciate your resilience. So yeah, these are some things I would like to ask of myself, maybe even assert of myself, because I also have needs. And then these are different ways of helping a client reinforce the relationship with themselves as they move forward. So yeah, obviously a lot more can be said about that. Let me just really, really quickly in the last few minutes zoom through some other interventions you can use, and especially once the client is more stable. I really like the satisfaction scale. So you help the client rate on a scale of 1 to 10 all of these different areas of their life. And the main reason for that is for them to realize, well, some areas of their life actually are going pretty well. Maybe some areas are tanking, maybe some areas are mediocre, but just for them to realize not everything warrants suicide. And then what you do is you help the client identify goals for whatever area the client wants to work on. Let them choose. And instead of us dictating what they need to work on, you choose. And then you explain Okay. So for, each of these areas that you would like to work on, I have some skills that I can teach you that will help you meet those goals. And that's the idea with DBT. Get them to use skills with the things they want to work on, to build their life worth living. Because we want them to see positive results with their skills work for themselves. Like, oh, I did this skill, this helped me with that. So that they can take ownership of these skills, and then trust me, these skills will start to leak out and they'll use them in other domains too. So after a crisis, that might be our cue to start having a client use a diary card, to start to track the things that led into the crisis. Something else, okay, and there's no one right way to do a diary card. This is just a diary card for someone that has PTSD. These are some typical things you might want them to track. For each client, this will be different. You also might want to do a chain analysis. Maybe not in that crisis session, but maybe the follow-up session, to figure out what were the things that led up to that crisis. And especially if it's a reoccurring crisis, how you handle the crisis actually set you up for another crisis. And this is just a simple way of helping clients see how one thing leads to another, leads to another, leads to another, but also helps clients start to see where they can apply their skills. I really like this intervention, especially for kids. This is a really good way to visualize DBT. So as you fill in all of these different prompts, these are all different aspects of DBT. And this can be, like literally a visual treatment plan for your clients. And then, yeah, just really, if I have time. Okay. So spirituality is a part of DBT. So some of your clients this maybe will apply to, and maybe with kids. Well, yeah, even with kids, I would say kids can be very spiritual. And so remember, one of the M in improve stands for meaning, the meaning, but then P stands for prayer. And prayer really represents any religious practice that a client has that works for them. And you can think of the M as any kind of spiritual understanding that a client has that works for them. Right? So take the meaning skill and the prayer skill to be much broader than those two words. And so this is what Marshall McLuhan says. For many individuals, spirituality and religious practice are very important in their lives. Such practices can be important sources of strength and also provide coping resources in different moments. And she goes on to say, leaving out a recognition, indeed, a recruiting of spirituality as a source of strength and sustenance runs the risk of ignoring the spiritual diversity of the populations we treat. Viktor Frankl, who absolutely inspired Marshall McLuhan, and she says that in her manual, says this: when a patient stands on the firm ground of religious belief, there can be no objection to making use of the therapeutic effect of his religious convictions and thereby drawing upon his spiritual resources. So if a client has some kind of spiritual understanding, religious practice that can help them through the crisis situation, right? Even if it's just a deterrent, then by all means leverage it. By all means. And I just threw out the Serenity Prayer because this is a poem that everyone universally recognizes as something that's helpful to many people, inspirational to many people. Obviously, there's a lot more to religion or spirituality than this, but okay, that's pretty much it. This is just a simple discharging planning questionnaire you can use for clients, and I really like this poem. You guys have probably seen this before. But yeah, that's the end of my slide deck. I've left 2 whole minutes for Q&A.
Kirby's gonna send out the slide deck, so you should all get that. And then if you'll check the chat, everybody, and make sure you sign in so I can send you your CEU certificates. And then now, if you have questions, you've got 2 minutes. So feel free to unmute yourself and just ask away.
And I realize 2 minutes is not enough. So if you have a question that's gonna involve like more time, by all means, email me. And then I will be on site for 3 days in a couple weeks anyway.
Yeah, there weren't a whole lot of questions in the chat. I think somebody asked about, I know you mentioned when you were talking through a student makes an outcry for suicide, not like sticking with that for the entire session, but somebody asked, do you do the safety plan at that time and then move on, or do you wait for a safety plan maybe the next time you see them?
Yeah, so what I would do is if they're verbalizing some kind of SI at the beginning of the session, I acknowledge it. And I move on with the session. I do basic mindfulness stuff, distress tolerance stuff, whatever skills I think will help. And then at the end, I check back in. And that's when I do the safety planning as necessary.
Perfect. Kirby does have a workbook. You should all have received that if you got the DBT training. If you didn't get DBT training yet, you will at the end of August for all of our new hires. So you'll get the book then, and he has a Spanish one as well if you didn't get that and you speak Spanish. So just let me know. And then, yeah, if you do have questions, I can invite you to maybe the end of one of the days coming up where he'll be in town for us. So just let me know in an email if you do want to stop by, and I can invite that for you.
And I don't think I've ever covered so much DBT material in 3 hours. So like,
it was a lot. Yeah.
thank you
You
so
did great.
much. If you were on the, if you had to be on the receiving end of all that, and the reason I did this rapid fire is because I knew most of you already had DBT, so I knew it was going to be kind of a review. But if you felt overwhelmed by all that, don't worry. There'll be 3 whole days to unpack all of this.
All right. If you didn't sign in, please check the chat for the link. Otherwise, enjoy the rest of your Friday. Thank you so much, Kirby, for the 3 hours, and we'll see you in a couple weeks.
Okay, sounds good.
Okay, bye.
Thank you.
Thank you.